Hello everyone, this is Dr. Agalya. We are going to continue our discussion about internal genital organs in this video. First we'll see about vagina. Okay. So in this picture I hope you'll be able to see vagina clearly. This is a cross section of the uterus. So this is the uterus. This is the cervix. And this is the vagina. Okay. So these are basically the adnexal structures. That is the tubes and the ovaries. Now what is vagina? Vagina is a fibromuscular hollow tube. Okay, and this extends from the cervix and it opens to the exterior through the introitus. Okay, now if we see the structure of the vagina, so let's take this is the cervix, this is the anterior vaginal wall and this is the posterior vaginal wall. So the length of the anterior vaginal wall is around 6 to 9 centimeters and the length of the posterior vaginal wall is around 8 to 12 centimeters. Now you may ask me, ma'am, why this difference between anterior and posterior vaginal walls? It is because the posterior vaginal wall is inserted at a higher level into the cervix than the anterior vaginal wall. Also, when these vaginal walls are inserted into the cervix, we get 4 fornices around the cervix. Okay, so these are the anterior fornix, posterior fornix and 2 lateral fornices. Obviously, the posterior fornix is the most deepest fornix of all the 4. What is the importance of this fornices? Fornix is helpful in differentiating between the prolapse of the uterus and congenital elongation of the cervix. Because in prolapse of the uterus, these fornices are usually shallow, whereas in congenital elongation of the cervix, the fornices are usually deeper. We'll see the relations of the vagina now. So if we take the vagina like this, we'll keep this as the anterior relations, posterior relations and we'll write the lateral relations here. Okay. So the anterior relations of the vagina include urinary bladder. We'll divide the vagina into 3 parts. So the anterior relations are the ureter and urinary bladder in the upper third. In the middle third, we have the bladder neck and the urethra, proximal part, and lower down in the lower third, we have the urethra alone. And the posterior relations in the upper third includes the cardinal ligament, and in the middle third, it is the rectum, and in the lower third, it is the anus and perineal body. In the lateral side, it is the rectouterine pouch or the pouch of Douglas and the uterosacral ligaments in the upper third, and in the lower third and the middle third, we have the muscle, namely levator ani. And the attachment of the levator ani muscle in the lower third of the vagina and the lateral wall is known as fibers of Leska. Okay. We'll see the layers of vagina now. We have 4 layers. So, from the lateral to the medial side, number 1 is the skin of vagina. Then it is the mucosa. Then it is the muscularis layer. And 4th layer is the layer of adventitia. Okay. If you see the vaginal cytology, we'll be able to see 3 types of cells, namely superficial cells, intermediate cells and parabasal and basal cells. Okay. Now, superficial layer cells have action from the hormone estrogen. Intermediate cells have the progesterone hormonal action, and in parabasal cells there is no such hormone action. Okay. So, why we have to know about this vaginal cytology? Because we calculate an index known as maturation index in case of pathologies. Okay. So, this maturation index during menopause, we'll be writing the ratio of cells as parabasal, intermediate and superficial cells. During menopause, the ratio is 100, 0, 0. We calculate an index called as maturation index using these cells. You have to know the normal value of this maturation index. In case of menopause, the ratio of the cells, namely the parabasal, intermediate and superficial cells are 100, 0, 0. Okay. In case of pregnancy, we have more number of progesterone hormone action, right? So, it is 0, 90 and 10 in pregnancy. And in case of menstruation, the ratio is basically 0, 30 and 70, and this is mostly seen during the proliferative phase of the menstrual cycle. Okay. Now, if we take a cut section of the vagina, it will be usually head-shaped and it consists of numerous rugae due to the action of hormone estrogen, which means it is a healthy vagina. Okay. But apart from the rugae, we also have sulci in the vaginal walls. There are basically 5 sulci. Okay. 3 annular sulci and 2 lateral sulci. The 3 annular sulci are, it is the suburethral or submeatal sulcus, then the transverse sulcus, and then it is the bladder sulcus. The 3 annular sulci are suburethral or submeatal sulcus, transverse sulcus and the bladder sulcus. Okay. If we exactly see the location of these sulcus, suburethral sulcus is located at the external urethral meatus level. Transverse sulcus is located at the level of bladder neck, and bladder sulcus is located at the level of bladder base. Okay. The importance of transverse sulcus is that it is a line of demarcation that helps in differentiating between the cystocele and urethrocoele. Whereas at the level of bladder sulcus, cystocele can occur. The two lateral sulcus are located at the junction of anterior and posterior vaginal walls. Now we will see about vaginal secretions. Remember, vagina has no glands. Okay. Now we will see about vaginal secretions. Remember the fact that vagina basically has no glands at all. Now you may ask me, ma'am, where do these secretions of vagina come from? It basically comes through the vaginal walls as a transit from the vaginal plexus. Second one, it can come from the cervix, and during coitus, secretions can even come from Bartholin's gland. Okay. So, generally, the secretions of cervix are alkaline in nature, but the vaginal secretions are acidic in nature. Now, again the doubt comes, if the secretions of vagina are coming from the cervix, how does these vaginal secretions become acidic? Yes, we'll see that. In the vagina, we have a special type of bacilli called as Dodderlines bacilli or the lactobacillus. Okay. Now, what this bacillus basically do? So, this bacilli, along with the estrogen action, it acts on the superficial cells. Superficial cells are also called as matured cells because there is more amount of glycogen in these cells. Okay. Now, due to this action, what happens is there is production of lactic acid by these bacilli, and this gives a acidic environment in the vagina. Okay. Now, number one, this acidic environment prevents from infections. It stops the growth of other pathogenic bacteria, and it facilitates the growth of lactobacillus. Okay. Now, what happens during menopause is that this estrogen action hormone is lost, and again the pH will become acidic. If you take a life cycle of a woman, birth and menopause, childhood, this is the reproductive phase. In the reproductive phase, two important events will be taking place. Number one is menstruation. Number two is pregnancy. Right? Now, how will be the pH of the vagina in these stages? Okay. First, the pH is said to be acidic because there is estrogen hormone action from the mother. Then it becomes alkaline in nature. Okay, and reproductive phase of the woman, most of the times it is acidic only. Okay, but during menstruation it becomes alkaline again because there is menstrual blood that is overflowing into the vagina, and during pregnancy it becomes more acidic. Okay, and in menopause, since the estrogen hormone action is lost, again it becomes acidic. Okay, so usually alkaline means the pH will be 6.5 to 7.5, and in pregnancy the pH will be around 4. Okay, so this is all about vagina. Now we are going to see about the fallopian tubes. Now we will see the blood supply of vagina. We will divide the vagina into two parts. The upper half receives blood supply from the cervical branch of uterine artery as well as from the vaginal artery. Now vaginal artery may come as a direct branch of internal iliac artery, or it may arise from the inferior vesical artery also. Okay, and the lower half drains into the internal pudendal artery. Okay, and the posterior half of the vagina also receives blood supply from the middle rectal artery. Okay, now coming to the venous drainage. Venous drainage of vagina happens into the venous drainage of vagina happens via the vaginal plexus of veins, and it drains into the internal iliac veins. We see the lymphatic drainage of vagina. We can divide it into upper 2/3 and lower 1/3. So the upper 2/3 drains into the para-aortic nodes via the obturator and iliac nodes. The lower 1/3 drains also into the para-aortic node. So it drains first into the superficial inguinal and deep inguinal lymph nodes. Then it passes to the femoral nodes. Then comes to the external iliac lymph nodes. Then common iliac lymph nodes, which will finally drain into the para-aortic lymph node. Next we will discuss about the fallopian tubes. So this is the structure of fallopian tubes. So you have interstitium part, isthmus, ampulla, infundibulum and the fimbriae. Okay, from medial to lateral. Okay, now interstitium part opens into the uterine cavity through opening, and this opening is known as ostium. Okay, so what are the four parts of uterus? It is the interstitium, isthmus, ampulla, infundibulum and fimbriae. Fimbriae opens into the abdominal cavity. Now, interstitium part is also known as anatomical sphincter. Isthmus is the narrowest part of the uterine tube, which is around only 2 to 3 millimeters, and this part is known as physiological sphincter. Ampulla is the widest part of the tube and it is also the longest part of the tube. It measures around 5 to 8 millimeter wide, and this is the region where fertilization usually takes place. Infantibulum has more number of ciliated cells. Okay. Now, if we see a cross section of the tubes, we have 3 layers. One is the mesosalpinx, another one is the myosalpinx, and another one is the endosalpinx. Mesosalpinx is nothing but the peritoneal coverage that is present surrounding the tubes. Myosalpinx consists of outer longitudinal fibers and inner circular fibers. And endosalpinx consists of 3 types of cells, namely secretory cells, and then you have the PEG cells. These are nothing but the inactive secretory cells, and then you have the columnar ciliated columnar cells. Okay, so these are the secretory cells and this is the ciliated columnar cells. Okay, so this is one picture to get an idea of the cross section of the fallopian tubes. So we'll have the secretory cell. Okay, in between the secretory cells we have the PEG cells, which are nothing but the inactive secretory cells, and also we have the ciliated cells. Okay, see, for example, this is the uterus of the tube. Okay, and ovaries are somewhere here in the pelvic cavity like this. Number 1, what is going to happen with the ovaries? Ovulation is going to happen. As the ovulation occurs, these ova are picked up by the fimbriae of the fallopian tube, and this is going to travel, and somewhere in the ampulla of the fallopian tube here, fertilization is going to happen. After this fertilization, this has to travel to the uterine cavity to get implanted, right? So the movement of the ovum and movement of the fertilized embryo has to happen through the fallopian tube only. So for this, a large number of ciliated cells are present which help in this movement. Okay. So since the fertilization is happening in the fallopian tube, it also becomes the most common site of ectopic pregnancy. Okay. So ectopic pregnancy, most common site is the fallopian tube, and in the fallopian tube, it is the ampulla of the fallopian tube. Okay. And next one, since the most of the fertile ectopic pregnancy is happening in the ampulla, most of the tubal abortions, okay, means the ectopic pregnancy can have 2 fates. Okay, either it can go for tubal abortion or it can go for tubal rupture. So now we know ampulla is the most common site of fertilization, right? Since it's the most common site of fertilization, it also becomes the most common site of ectopic pregnancy also. Okay. Now, this ectopic pregnancy can have 2 fates. Okay. Either it can go for tubal abortion or it can go for tubal rupture if it is formed in the tubes. Tubal abortion most commonly happens in the ampulla since it is the most common site of ectopic pregnancy, and tubal rupture most commonly happens at the site of isthmus because isthmus is the narrowest part of the fallopian tube. Okay. Also remember, isthmus is the site where we are going for ligation. Okay, tubal ligation, that is during sterilization, the tubal ligation is done at the site of isthmus. Okay. Now it is also important to find these tubes correctly during sterilization procedures. So it is mostly done with the help of fimbriae. So this helps in differentiating it from the round ligament from the fallopian tubes. Okay. Now we will see the blood supply of the fallopian tubes. So the arterial supply of the tubes in the lateral half is by the ovarian artery, and in the medial half it is by the uterine artery. Okay. And the venous drainage is by the uterine plexus of veins in the medial half and the pampiniform plexus of veins in the lateral half. Uterine plexus drains into internal iliac veins and pampiniform plexus drains into ovarian veins. Regarding the nerve supply of tubes, it has sympathetic nerve supply and parasympathetic nerve supply. Sympathetic nerve supply is from the T10 to L2 nerve roots, and parasympathetic nerve supply is by the pelvic splanchnic nerves, in the medial half and via the vagus nerve in the lateral half. Lymphatic drainage goes via the paraortic lymph nodes. Okay. Now we will see about ovaries. Ovaries are the female gonads, analogous to testes. These are located in the pelvic side walls, and the specific location of ovaries in the pelvic side walls is the ovarian fossa. We have to know the boundaries of ovarian fossa. Ovarian fossa superiorly we have to know the boundaries of ovarian fossa. Anteriorly, it is the external iliac vessels. Posteriorly, it is the ureter and internal iliac vessels. Laterally, it is by the obturator nerve and infundibulopelvic ligament. Medially, it is by the ovarian ligament. Okay. So if you see this picture, you will get an idea. Okay. So anteriorly, it is by the external iliac artery. Okay. And posteriorly, it is by the ureter and internal iliac artery. Okay. So laterally, it is by the obturator nerve and infundibulopelvic ligament, and medially it is by the ovarian ligament. So this is the suspensory ligament of ovary, which is also known as infundibulopelvic ligament. Okay. This is the ligament of ovary that is attaching the ovary to the uterus. Suppose in case if you want to remove the ovaries during hysterectomy, we have to cut through this infundibulopelvic ligament. Okay. Now we will see the cross section of ovaries. If you take a cross section through the ovary, Okay. The outer layer is the cortex and the inner layer is the medulla. Cortex is generally surrounded by a layer of germinal epithelium. And in the cortex, there are follicles which grow for growth and becomes a mature follicle. Okay. So ovulation happens basically from the cortex. Due to repeated ovulation, the outer surface of the ovary will look rough. And in the medulla, we'll have blood vessels, lymphatics, and cells called as Leydig cells. If we see the size of the ovaries, it is 3 cross 2.5 cross 1.5 centimeters, and normally the volume is around 6 to 8 cc. What is the blood supply of ovaries? Ovaries are supplied by ovarian artery, which is a direct branch from aorta. And this artery arises at the level of L2. Okay. So it comes and reaches the ovaries, and in the hilum of the ovaries, this will be dividing into numerous branches and it will be supplying the ovary. Venous drainage of the right ovary goes into the inferior vena cava, and the left ovary goes into the left renal vein. Nerve supply of the ovaries. The sympathetic nerve supply is from the ovarian plexus of nerves, which is derived from the renal plexus. Parasympathetic nerve supply is through the vagus nerves. Lymphatic drainage is through the para-aortic nodes. Okay. Now, what is the importance of the ovaries? It plays a critical role in ovulation, menstruation, and conception. And the size of the ovaries varies throughout the reproductive cycle of a woman, and it can be affected by the endogenous factors and exogenous factors also. Okay. So, exogenous factors are mostly due to hormonal supplements like the OCPs. There can be numerous many follicles that are seen in the ovaries, which is known as polycystic ovarian disease, and it can lead to many hormonal changes. And sometimes functional cysts also exist in the ovary. The various types of functional cysts include follicular cyst, theca lutein cyst, etc. So finally, this is the cross section of the ovary where you will be able to see the cortex and the medulla. Okay. So finally, we'll see the cross section of the ovary. So this is a picture of ovary showing its cross section. So you are able to see the cortex and the medulla. In the cortex only, the follicles are growing and it is going to ovulate, and soon after that corpus albicans and corpus luteum are also seen here. Okay. So with this, we are finishing the anatomy of the internal genital organs. Until we meet in the next video, happy learning, keep going and take care.